My main role in the Shine Care Home project was as one of the clinical pharmacists. What I would do is go to GP practices to review their records, to give the background on why medicines were prescribed. We would then take that information to a multidisciplinary team review involving the pharmacist, the care home nurse and the GP. That review would then generate potential interventions, what we would suggest is useful actions on medicines. Those potential interventions would then be taken to the patients or where they don't have capacity to be involved in such decisions, family members, and that would then generate the final decisions on what to do with medicines. All that information was then input into the GP records, and I would follow up patients after the intervention to make sure there were no negative consequences. Shared decision making is a collaborative process where a healthcare professional will support a patient in making decisions about treatment options. So within shared decision making, the healthcare professionals bringing the evidence, potentially the outcomes to be expected, and as well as that maybe some negative effects that patient could experience and how likely it is that they could experience those. The patient will be bringing their values and their priorities into that decision making, so together they make a better decision that's more suited to the patient. In the care home project, the shared decision making aspect was in deciding, following the multidisciplinary team review, what the patient's preferences were for any decisions on their medicines. The benefits of shared decision making is it's very important that we give patients a voice on decisions on medicines that they're taking. In care homes in particular, this is an environment where residents get little say in their medicines and little say in the decisions about their treatment. And as well, patients aren't responsible for the administration of medicines, so it's quite often that they don't actually know which tablets they're taking. One of the key things with this project is, before we made any decisions or suggestions about what we could do with medicines, it was important that we had an accurate background as to why medicines were prescribed and whether the patient was still benefiting from them. When we discussed medicines with patients, they were able to provide some additional information on background to their medicines, perhaps the response to treatment, and that gave us a better idea of whether or not medicine was benefiting the patient. And it may be that following the MDT review, we decided from discussion with the patient that actually they were benefiting from it and we would continue treatment. There was a question of who the best person to involve in decisions about medicines. In all cases, ideally, this would be the patient themselves. We did find with a number of the residents in the care homes that actually they weren't familiar with being asked for input on medicine decisions. For those cases, we would engage them and explain to them why we were seeking their input. In care homes, unfortunately, not every resident has capacity to be involved in decisions about medicines. In those cases, we would go to family members to seek their advice and their thoughts on perhaps what the wishes of the resident would have been. When trying to convey the benefits and risks of medication, it can be quite difficult for some patients to understand or to comprehend, especially when we're discussing statistics. For several cases, there are some shared decision-making tools which give a visual representation of these benefits and risks, and that can be easier for the patient to understand. We know there are perceived barriers to prevent shared decision-making from occurring. One of the commonly cited barriers is time. In our experience, we showed that time can actually be an efficient use of resources. There was one patient I came across who had put frequent calls out to the GP and practice staff to come and review medicines, and this was actually occurring on a weekly basis. In having the pharmacist actually explain medications and treatments to the patient and the family, actually that led to them no longer calling the GP for advice, so actually in that case it saved time. Another perceived barrier in the care home environment is that none of the residents have capacity to be involved in decisions about medicines. We showed this wasn't the case, and the residents in our study, 16% had capacity and wanted to be involved in decisions about medicines. Another barrier is perceptions that those residents can't comprehend those decisions, the complexity of those decisions. And again, we showed that wasn't the case. When we actually broke down the decision and explained to the resident that we weren't expecting them to take responsibility for the the evidence or the clinical expertise, but really was trying to get their wishes, actually they were able to contribute to even complex decisions about medicines.